Hello, everybody. Welcome. I'm Alex Thompson. I'm a senior lecturer in health economics based at the University of Manchester. Really pleased to be chairing this session with James Chapman, who is from Decently. It's a great name for a company, and I've been working with James for 6 months maybe, and it's a really appropriate name. They're lovely, lovely people. So really pleased to chair this session. So without much further ado from me, I'm going to pass over to James, who's going to give you some great insights of his experience so far developing a digital app for the NHS. James, over to you.
Thank you very much, Alex. Well, first of all, thank you very much for that kind introduction, Alex. And yeah, it's fantastic to be here on the seminar this afternoon. Alessandro was just sharing with me that this particular seminar group has been up and running now for a couple of years in collaboration with Cambridge. So yeah, thank you very much for inviting me and thinking that I had something worthwhile to share. I guess we'll see the attendees view of that when you get your survey in, but hopefully this is going to be an interesting next 25-30 minutes, and then plenty of time for lots of questions. So the topic that we've been asked to talk about today is, as it says on the tin, it's all about how are we bringing a new technology into being in collaboration with the NHS, but specifically around some of those challenges and the pitfalls, so that if you're working on digital health projects yourself, or maybe you've got ambitions in the future to work in a startup or to start up a startup, to spin something out from university, then hopefully some of the lessons that we'll share today, which we've gathered along the way, will prove useful to your own work. In terms of what I was going to cover, I've tried to split it into kind of 3 chapters. So a little bit about, well, what do we actually mean by digital health? You know, we could probably ask everyone on the call to give us their view, and we'd have quite a range of different answers. Then specifically dive a little bit deeper into the NHS. I have spent some time working in the NHS, but I'm not NHS kind of born and bred, so it's still a bit of a maze at times to me, but I'll share my kind of understanding about the NHS and how health tech fits into that landscape. And then I've tried to pull together some of my own personal views and experiences around building digital technology within the NHS. So they're kind of the 3 chapters of the presentation, and then yeah, plenty of time for Q&A at the end. I'll just go back. So first of all, a little bit about my background as to why hopefully, you know, some of my experience is relevant. I never like doing these kind of big upfront indulgent, here's my career history, and I'll talk about it for 25 minutes of the presentation, because I guess we want to get into the presentation. But I think the 3 things that I'd like to call out is that I've worked in health tech now for almost the last decade. As part of that, I've worked in the NHS, so I've sat on the other side of the desk, or the other side of the collaboration, and specifically that role was looking at bringing innovation into the NHS, so got some experience there. But most recently, for the last 3 years, I've been a co-founder of a digital health startup business called Decently. We're based in Manchester. I'm in the Technology Centre on Oxford Road today, so maybe not a million miles away from where some of you are. We've been building a new digital health solution. I will tell you a little bit about that later on in the presentation, but this isn't a pitch for our product. This is about digital health in the NHS. So digital health tech, when I was thinking about it yesterday, you know, for those people who this isn't their space, I wanted to start at a fairly accessible entry level. So I looked up, you know, what does the World Health Organization actually define as health tech? And the biggest thing that jumped out at me for this was the last bit of the sentence. Not the technology itself, not the devices, the medicines, the vaccines, the systems, the AI, the apps, the wearables, the sensors. There's a whole range of technology out there. But actually, for me, health technology should be solving a real problem. And I think that's going to be a theme that I'm going to come back to today as we go through the presentation. Going a little bit deeper though, and a little bit closer to home. So NIHR, that's the National Institute for Health Research, and they have a big influence on health tech within the NHS. They define it a little bit more sort of granularly. So, you know, it's all about boosting health and well-being. But again, back to that, what's the purpose? What is the clinical problem that we're trying to solve with this? And I think any good health technology that I've seen succeed spends just as much time thinking about that than they do how to code it, or how to patent protect their algorithms, or how to, you know, actually get their sensors, you know, made and into action. That's really important. But actually, what's the core of what you're trying to do? How are you solving either a clinical or a patient need with that technology? When you look across the range of different health technologies that are out there on the market, and there's some really, really great examples, you know, some of these only exist within pockets of innovation. You know, I don't think every hospital at the moment has, you know, equitable access to devices and internet, and, you know, there's still paper-based processes aplenty, you know, if you look across the NHS. But there's been a lot of investment within the NHS over the last decade to start to bring some of these technologies into just how we work. And we'll elaborate a little bit on why that's important. But if you look at the range of things, you've got everything from digital, you know, which is where a lot of my time has been spent building digital solutions, whether that is a pure software play or including some integration with some hardware, all the way through to things like nanomedicine and biomarkers. So I'm going to disappoint anyone if they're here today to hear about that end of the spectrum, because that's not my specialism. But I think, you know, the range of technology that is out there in healthcare is phenomenal, and it's a really, really exciting space to work within. In terms of the space that I've occupied for, you know, the last sort of 10 years or so, I'd see it's pretty much in this space. So, you know, when you're thinking about mobile health apps, you know, something that you might download to help you because you've been recently diagnosed with chronic kidney disease, you know, and you want some information, or you want to be able to track your progress through that pathway. You know, wearable devices. Once worked on a project that was helping people recovering from acquired brain injury be more self-sufficient in their home. And it was all about making sure that they were safe and independent when they were preparing a meal. And the sensor in the wearable, it helped detect their movement. It helped detect if they'd wandered off and left a stove on, left a pan on the stove that was maybe going to overheat. So there's lots of really practical projects that I've had the pleasure of working on that fit into a lot of these different categories. And I think that's where my personal kind of expertise is. So why digital? You know, why do we think that health tech or health in general, you know, needs to go on a bit of a journey to come up to the same level, I guess, as a lot of other industries and sectors are? Well, I guess for anyone who's worked in this space or has, you know, got an interest in digital, there's a lot of obvious benefits. You know, it's more accessible. You know, you can scale it quicker. You know, if we build an app that is used by 100,000 patients, then that's much easier than having 100,000 face-to-face appointments, or having to have 10,000 new healthcare staff to deliver those services. It can often be cheaper because of those economies of scale, and it can have a positive impact on empowering people, whether that is a clinician. And I think of clinicians as a broad range of healthcare professionals. So anybody who is looking after a patient in a GP setting, an inpatient setting, you know, a community setting, somebody who's employed by the NHS to look after someone. But it can also empower citizens and families and carers and individual patients to manage their own conditions. However, there are concerns and there are challenges. Like with anything new, if you're trying to bring a disruptive solution into a new environment or a new market, then there's always going to be concerns around that. And I will touch on some of those later on in terms of some personal learnings around this. But it's not, you can't get away from the fact that not everybody is technologically literate. Not everybody has equitable access to a smartphone or even the internet. The fact that we're on this call and we're all dialing in probably from a relatively nice laptop, whether that's our own or whether that is paid for by your employer, not everybody has that. And that's within hospitals as well. You can go into hospitals around the UK and they are still lacking in terms of infrastructure. They are lacking in terms of mobile connectivity or devices to be able to actually access some of these innovations that are coming out. There's also a big element of trust and compliance and safety within health tech. So how do we know that these things that app developers or spin outs from universities or collaborations with health tech organizations, how do we know that they actually work? How do we know that they're safe, that they've been clinically validated and approved, or actually is this something that's been rushed out and has not gone through a rigorous process to ensure that we aren't creating harm when actually we are trying to avoid harm? The research side of things, so I'm not clinical by background, and therefore we rely on working with much more qualified and smarter people than we are within our team to bring in that research, to bring in the evaluation of what's already been done, whether that's around the clinical evidence, whether that's around the healthcare impact that technology can have. You have to have quite a broad church of people to build a really good digital health technology, and you can either have lots of cash and employ them all in your own company, or you can look to build collaborations. And I think being on this call today is a result of the work that we're starting to do with the university, but working with other organizations within the NHS, across academia, and into other organizations as well is really key. If we take a step back and look at the kind of the global picture around medical technologies, and this is zooming in on medical apps, but I think it's a general trend across all of those different categories of health tech. Over the last 4 years since the pandemic, especially, we've seen a huge explosion in digital because we had to. We responded to a global pandemic, and we all shifted to a digital world, some easily, some not so easily, but that correlated with a trend that was already underway around probably over the last 10 years, where mobile technology has become more common. People are looking to use that access to the internet and access to technology to manage their own health. And they also have an expectation that when you go to see a healthcare worker, whether that's a GP or someone in a hospital or a consultant, you almost probably have the same expectations now of other industries that you go into. We book our holidays online, we do our shopping online, we communicate online. And I think there's just an expectation that health should be moving in that direction as well. And I think that trend is going to continue. Look at it from a slightly different angle. These things are, if you're bringing a new technology into any sector, you need capital to do that. You need a team to do that. You need resources. You need time to do that, because building within health tech is not the same as building an app for a local business or a retail brand that you could probably get it out fairly quickly and just see how it goes. There's a lot of work that goes in up front before you can put something into the hands of a clinician, especially if you're putting patient data into that. So that itself requires investment, and it requires money. Looking at it from a VC perspective, the trend has dropped off a little bit since 2021. I think we saw a huge explosion, again, off the back of the pandemic, where digital health startups were able to generate and attract high levels of investment because there was a little bit of a bubble. We have seen that drop off, but that upward trajectory definitely continues. However, bringing it, back down to you've started something new, you're trying to work with the NHS, you're trying to bring something to market, then it's sad but true. But a lot of companies don't survive the first couple of years. When you look at that within health tech, there is actually over 5 years there is a slightly higher survival rate for these companies. But when you look at the reasons why the health tech startups tend to fail, it tends to fall into 4 categories. One is around kind of access to funding. So they simply run out of money within the course of their lifetime. They don't find product market fit. So going back to starting with the problem and understanding what is the clinical need that you're trying to address, they just don't address that. The third one is access to the right team to build. And that's not just having the right technology people in your team, it's having the right clinical input, the right academic input, the right regulatory input. And the fourth one is regulation. So if you don't plan for the regulatory barriers and hurdles that come in health tech, you'll probably hit the rocks at some point. And they are the 4 main reasons why health tech companies don't tend to survive if they go down that route. Notice I didn't mention anything about the technology in there itself, and we'll come back to that later on. So there we go. There's a little recap of that. So no need for the product in the first place. We built something that nobody was actually going to use. We run out of money. We couldn't get our model right. We couldn't access the market and those legal and regulatory issues. So that's chapter 1 about health tech itself, and we're going to now move into the NHS and how health tech is playing an ever more important role across the NHS. So for anyone who has been in an NHS situation, I imagine that's probably most of us, we've probably all been to see a GP or been in hospital. Some of these stats may be new, but when you step back from your actual touch point with the NHS and look at that as an organisation, it is one of the world's largest employers, employing nearly 2 million people. So that is a huge organisation of complex human beings who some are probably more resistant to change and some are, probably wanting to go quicker. So there's a lot of complexity in bringing change into the NHS. They're also serving over 1 million people a day. Imagine if that was your business, if you were providing services to over 1 million people a day. That is a huge responsibility, and there's complexity that comes with that as well. The NHS that you see on the left, the one badge that we all know, the blue and white, the NHS itself on the inside is not one organisation. Now that might sound really simplistic and obvious to some people. For some people, you might think, oh, well, I thought it was all quite joined up. No, it's not. There's over 200 individual NHS trusts across England alone. There's 50 mental health trusts, there's 10 ambulance trusts, there's now things called ICBs and ICSs, and like any large organisation, the NHS is continually changing, so the landscape never stays still for very long. And to understand and get anything done in that complexity, you need help along the way. And obviously, we all know that there's a shortage of on the supply side, from the ability to see people, long waiting lists, and this is because we've got a lot of people needing access to the NHS, but actually there's only around 140,000 beds available at any point in time, and that has actually halved over the last couple of decades. Looking at it from a population point of view, it's probably no surprise that, to focus in on the fact that we are an aging population and there are more of us, but that in itself is not the problem that is increasing the demand on our healthcare services. It's the fact that as we live for longer, we are developing sort of interrelated illnesses and conditions, and it is that is placing the demand on the NHS. So as we live for longer, which is fantastic, modern medicine, has increased the average lifespan within within Western countries, especially. However, the longer that we live, the more that we're seeing people suffering from heart disease, cancer, asthma, diabetes, brain injury. And it's the cumulative effect of those that there's more of us, but we've also got more issues as we get older. So that leads to this sort of tension that you see within the NHS, an increase in level of demand on one side and a decrease in capacity on the other side. And these were just some stats that I found around kind of GPs and waiting times to see a GP. We've probably all been in that situation, so I thought that was more relevant than something quite niche. But I think you could take yourself out of that and imagine if you were trying to wait for a hip replacement or a cancer screening or a rehabilitation appointment. So this balance or imbalance that we're seeing across the NHS, I think is very real, and the NHS recognises that, and it's not unique to the UK, but we are talking about the NHS today. And there's probably lots of headlines that we've all seen over the last few years that the NHS is almost getting to crisis point, and the A&E is swamped, that we can't provide the level of services in the traditional models that we would like to, and we're starting to see the impact on that play out. I've made a deliberate point today to not get political at all, especially as we're only a number of weeks away from a general election, and who knows what might happen in the future. But I don't think that whichever government is in place by mid-July is going to have a vastly different picture. The starting point is still going to be the same. The challenges are still going to be the same. However, the NHS, isn't blind to these issues, and they published something called the long-term plan. This is a couple of years ago now, but by nature, it's meant to be a long-term plan over sort of at least a 10-year trajectory. And a big part of that, as you can see in point number 5, is about technology. So I'm not going to go through all of the other areas today because, the topic we're here to talk about is technology. I'm not going to go too deep into the long-term plan either because it's publicly available, and if people want to go and dig into it, they can do. But effectively, chapter 5 of the long-term plan, the goal that it sets out is to say that digitally enabled care will go mainstream across the NHS. This will obviously be beholden to funding and changing priorities and government, sort of policy setting. But over the next 10 years, the NHS has said we have to change. We have to bring innovative technology into how we provide care to patients. And this isn't starting from now. This isn't, a line in the sand that we're saying in 2024 that things have got to change. We've already seen some really great examples across a whole range of different areas within health tech, where technology has been able to be brought into the mainstream, that it's been built in the right way, that it's been proven can be clinically effective, that it's regulated, and these are starting to now form part of the fabric of care within these different areas. My own personal view is that this is almost the tip of the iceberg, though, and we're going to see a lot more digital solutions coming into this space over the near future. So what have I learned in the time that I've been working in this space? Well, I shared with Alessandro when we opened the call that it was actually quite nice to sit back and reflect. And I still don't feel like I'm an expert in this space whatsoever. I feel like I'm learning every day, but actually working in this space for nearly a decade, you do learn things. And I guess if any of you in your own roles was to take some time out with a cup of coffee and put some slides together on what you've learned over the last 10 years, then you'd probably be quite surprised at some of those lessons that you pick up. I'm going to, before I jump into that though, kind of try and bring this into the here and now for what we're doing at Decently. So we are building a digital health solution, and it's all about helping clinicians understand patients with complex behavioural issues. This is focused within neurorehabilitation and dementia. So in neurorehab, if a patient suffers, let's say they've suffered a fall, they've fallen in the street, they've tripped over a slab, they've been injured in a car accident. If your front left temporal lobe is damaged as a result of that, then you are highly likely, it's around 1 in 3, 2 in 3 people will go on to have challenging, complex behaviours as part of their rehab. Within dementia, 1 in 2 of us is probably sadly going to develop dementia or Parkinson's in our lifetime, and behavioural challenges within that particular patient group are also, on the rise. So we've been building Mello for the last couple of years, and we're now at a point where we've, I won't say we've finished, because I don't think any product is ever finished, but we've built a new technology, we've built a new innovation. This is very much a decision support platform to help clinicians to understand those complex patient behaviours. So this isn't an app that you would download off the App Store if you'd had a brain injury and you were lying in bed in Salford Royal. This is where the clinical team at Salford Royal, and they are one of our partners, would use Mello to conduct assessments, to look at that data, to look at those trends, and to use some AI tools to ultimately to make that data more accessible and actionable, but to plan and predict where they can make a difference to stop escalating behavior patterns getting in the way of someone going through their rehab journey. We've been doing this for a few years now. So as a business, we set up back in 2021 after I spent some time working in the NHS. And we've been backed along the way by a number of partners, including the Greater Manchester Life Sciences Fund, Innovate UK, and the Science and Technology Facilities Council. We're now working with 3 hospitals, so 2 of those are neuro rehab, 1 of those are dementia. So we recognise that we are still relatively early in our journey with Mello, but some of the lessons today are kind of things that have definitely been important to us over the last couple of years, but also some from some previous work that I'd done as well. I'll skip on past that one. So the first thing to say is, going back to the nature of creating a startup and creating something new from scratch. I guess this is like any project really, whether you're planning for a wedding or you're trying to submit your next NIHR bid application. You put your plan together, and the reality is always somewhat different. And I think some of the pitfalls, if you don't know that they're coming in digital health technology, can really set you off track. They can be the things that could ultimately make or break whether you succeed. And if not, they're definitely going to add some more time, some more complexity, some more effort, some more cost into delivering on your plan. However, a disclaimer, these kind of 12 kind of bite-sized lessons, none of it actually involves the technology. Now, people might say that this is a bit flippant because I'm not actually a coder. We've got a team sitting out here today, and what the work that they do is amazing. It's still magic from my point of view, and that requires skilled software engineers, AI specialists, data scientists. But actually, I don't think the technology itself is the hard bit. I think we know how to build technology, we know how to build solutions. Some of the other things that go around making technology a success is where you need to have a bit of understanding, maybe a bit of experience, because you don't know what you don't know. The first one of those, I'm just going to do a quick time check, so I'll probably rattle through this in the next sort of 5 to 10 minutes. The first one of those, in my view, is that co-design is absolutely critical to what you do. So for me, that means starting with the problem, starting with clinicians and working with them to really understand, how is this going to make a difference? How is it going to be used? What clinical decisions is it going to enable you to do differently? How does this improve patient outcomes? There's a whole host of areas that we spent time, probably the first 12 months, we spoke to probably 200 upwards clinicians, occupational therapists, physios, speech and language therapists, we ran workshops, we did focus groups, we did surveys, you know, and that was before we even laid down a line of code. However, I think going back to the point right at the start about what problem are you solving, if as technologists we just leaped into building a solution, we probably would have got it massively wrong. We probably would have spent time and money building something that ultimately, when we launched it, wasn't the right thing, or it wasn't designed in the right way. And when you speak to people on the ground in hospitals, they're actually fed up with substandard technology solutions being thrust upon them. You know, people bringing in solutions for the sake of solutions, people bringing in solutions that actually aren't any better than what they had before. So that whole kind of change curve, I think you can really get ahead of that by spending a lot of time doing co-design and do your research properly from a user point of view. Clinical standards, this is massively important, and that's why I've put it up front, but there are a number of organizations that I'll probably just draw a little bit of a highlight to today. There's probably a whole host of others out there that I won't talk about, but NHS England, NHS Digital more specifically, used to exist as a standalone organization. That's now been subsumed back into NHS England, but NHS Digital still kind of exists. They are a fantastic source of information, of guidance. If you want to build a digital technology, they have a whole developers kind of toolkit and lots of process and checklists that you can use around standards. So if you are going to go and build something, you know that ultimately it's good enough. The National Institute for Health and Care Excellence, people are, again, maybe familiar with that organization, but they set the standards in terms of care. So if you're working on something that is very specific to a particular patient group or a particular type of disease or a particular type of clinical problem, you probably want to go and have a look at what evidence already exists. Are there guidelines out there around how you would treat chronic kidney disease, for example? Are there guidelines around falls prevention? Are there guidelines around X, Y, and Z? That's a really good starting point. And Orca are a private organization, but work very closely, almost, you know, side by side with the NHS, and they exist to try and help improve the standards around digital technology and how patients and clinicians can have that element of trust. So they have like a 350 point, kind of like an MOT, you know, for your health application. And you have to go through a rigorous process with them to be ultimately endorsed by them and be on their app library. So again, a really good starting point if you're looking at standards. Regulations, I've split this differently. I probably could have put those two together, standards and regulations, but regulations are about the things that you have to have to do business with the NHS. MHRA regulates medical devices and medicine. So if you were designing a new medicine, you absolutely need to work with the MHRA. Medical device is a little bit more sort of a grey area, I'd say. So right now, Mello, for example, is not deemed to be a medical device because we're not automating any decision making for the clinician. We are deemed to be what's called a decision support tool or a clinical decision support tool. So that means that we're not a medically regulated device. However, I've seen other innovations accidentally trip over the line into becoming a medically regulated device without realizing. And then when they come to take their innovation to market, it's a huge surprise. There's lots of overheads and there's lots of almost re-engineering or backwards engineering that they need to do. So the MHRA has a really useful decision-making tree on their website. So I'd encourage anyone who's either working on a project or thinking of a project to probably have a look at that and early on establish, do you think you need to be a regulated medical device? Because if you do, there's quite a different path that you would go down than if you weren't. DTAC and DCB are more relevant in the digital space. But DTAC is the overarching set of regulatory standards that the NHS expect you to have. So it stands for the Digital Technology Acceptance Criteria. And this took us about 12 months to get in place because it's not one certificate. It actually covers a whole range of different things, like your DCB, which is a clinical safety sign-off process. So we have to have a clinical safety officer work with us as part of our company, and he has responsibility for ensuring that whatever we put into Mello is not going to cause clinical risk. It's not going to go wrong. It's not going to provide the wrong advice, and that could lead to harm for the patient. There's a whole host of other things under DTAC, but I probably won't go into those today, but definitely have a look at that. NAC are an organisation that we work with, and they've got a strong growing presence in the UK that they can actually help with all of this. So if you're sitting here going, yeah, that applies to my project or something that I'm working on, but I've no idea where to start, then probably go and have a conversation with NAC. Funding, as we said, probably one of the biggest reasons why any startup fails, but particularly within health tech, we know that the time to develop a good, robust clinical product is probably quite long. You know, when we set out at the start in 2021, we said this is probably going to take us 2 years at least, you know, to get to the point where we can have something safely in somebody's hands. Now, that's going to take money to get there. So there's a whole range of different funding mechanisms available to organizations. Some of the ones listed across the top, like Innovate UK, SBRI, NIHR, you know, they are competitive, you know, and they require a certain science and an art in getting the grant applications right. But if you can attract funding from those bodies, generally it's non-dilutive. So if you formed a company, you're not giving away equity in the same way as you would be if you went to a VC or an angel investor. But they also normally provide wraparound support to you as well, and can open up, you know, opportunities and doors for you. Health economics. Alex will be glad to hear I'm not going to profess to know a lot about health economics, because that's why we work with him. But the health economics side of things is massively important, because if you ever have an ambition to get your product to the point where it's being commissioned and it's sustainable, then it's probably not enough to just be safe and to be effective in terms of being adopted. You need to have a really strong health economic case around it. The NHS is not flush with cash. That shouldn't be a surprise to anyone. So most of the time they're looking for innovations that are going to at least be cost neutral, if not offer a cost saving. And being able to build that health economic model alongside your initial pilots or your early adopter trials is really important to gather that evidence as you progress. Similarly, on the clinical evidence side, so again, there's a whole host of information out there from the likes of NICE, and the evidence standards framework would probably be my recommended starting point, because this essentially helps you figure out where you sit in terms of what you've built. So is your, you know, is your innovation tier A, is it tier B, is it tier C? And then that gives you a pathway then for what level of evidence you need to build. And in terms of evidence, this is probably something that's been the biggest learning point for me. I remember my very first meeting with an NHS person talking about a different innovation, and they said, well, can you show me the evidence? And I was almost like, well, what do you mean by that? You know, and evidence itself is quite a broad term. You know, that could be at the lowest level, it could be bringing in some expert opinion and capturing the voice of the clinician, or how it's making a difference, all the way up to, you know, things like randomized control trials and systematic reviews, which are arguably a lot more complex, take a lot more time, and you need the right people involved to help you do that. So figuring out what level of evidence you need that is relevant to your innovation, to the stage that you're at, is really important. Clinical advocacy, we probably couldn't have got anywhere with Mello without Dr. Tiga, who's on screen there. And that's because he believed in what we were doing early on. He got involved. We won some funding together. He brought it into Salford Royal. And he's really, really passionate about the difference that Mello can make. So again, I would encourage anyone to find to find your Alistair, as it were, to find your clinical sponsor, that person who's going to give your product way more credibility than you ever will do. Navigating the system, we talked about the complexity of the NHS and how there is no one front door to go and knock on and ask for a meeting. Fear not, though, there are organisations within the NHS that are actually there to help you navigate that system. So they used to be called the AHSNs, which doesn't roll off the tongue. They're now called the HINs, which is slightly better, but the Health Innovation Networks. So there's 15 of these regional bodies around the UK. Within Manchester, Health Innovation Manchester, just down the road from the university on Oxford Road. Really, really helpful organisation. So if you're starting out on your journey, I'd encourage you to make contact with your local HIN, and they can signpost you then to funding, to grants. They can help you open doors and make connections. They can help you find pilot sites. And then if your product is a little bit further along in terms of maturity, they can help you build that health economic model. They can help you build your value proposition and ultimately, you know, see if it's something that can be rolled out and adopted more widely across the system. Nearly there, a few more. So reimbursement. I think if you've got ambitions to make anything sustainable, you need to ultimately be thinking about, well, where does that go when the funding runs out? Where does that go when the Innovate UK grant fund or the angel investment that you've secured, you know, comes to an end? Because that will happen. And for anything to be sustainable, there needs to be a sustainable business model or economic model behind it. So there's a whole range of different ways that you can think about that, depending on the area that you're working in, the type of innovation that you've built, but working through some of those options early and starting to test them with your potential customers or your market. This is something that we are doing now. We don't have the answers to this yet for ourselves. You know, this is something that we're trying to test out, that what is the right kind of price point for what we've built. And I think that's going to be an ongoing journey for us as we go further with Mello. Patient data and integration. We talked right at the start about trust and clinical kind of safety. So this is a little bit techie, this one. I've said that, you know, the technology isn't the hard bit. This is probably the hardest bit of the technology aspect, because the NHS is big, it's complex, there's over 200 odd trusts. That means there's lots and lots of systems within the NHS. They don't all have one patient record system, for example. So if you are building something that ultimately you want to be able to talk to those systems, to be able to integrate and maybe pass the information that you've collected through your app back to a GP system or into a hospital system, you need to go and have a look at something called HL7 FHIR, which is basically the standards that you need to build your APIs and your technology to. That is the most techie one of the 12. Trust, we've already talked about, was why this is important, but I think, you know, to hammer this home, and I don't take this personally, that, you know, consumers don't really trust app developers with their data, because I think that that's a responsibility that we have to you know, shoulder, and we have to take that really seriously. But recognizing the fact that there are concerns about what happens to data and what we're doing with that data, and have we got the right levels of consent, and are we treating GDPR with the respect that we should do? I think a lot of companies maybe don't see that as important in the early stages. We did, and you know, I think it's helped us stand out by having some of those things in place much earlier than maybe what other early stage startups would have done. And the last one, but not the least one, is around staff adoption. So if you've built something and it's great and it works and it's safe and it's regulated, and you expect to just switch it on and walk off, and then, you know, it's being used for forevermore, then you've missed the trick. And I think, you know, working with the teams locally within the NHS, within the trust, because there are things that are not directly within your control, but could make or break the success of the rollout of your innovation or your project. So won't talk about budget because I think we've already touched on that one, but there's inherent resistance to change in some areas. We've always done it like this, so why would we need to do it like that? The access to technology itself, but also the training and the support and the nurturing that goes around that. So I think that's probably my final lesson before we sort of take any questions, but thinking about once you've built it, how do you sustain it? How do you work with the local research and innovation teams, the local clinical teams, to think about that workforce piece? Because just because you built something, doesn't necessarily mean that people are going to use it. So on that, I think that was all I wanted to share. I probably have gone a little bit longer than I thought originally, but hopefully that's been useful and of interest.
Brilliant. Superb presentation, James. Thank you so much.